I am Dr. Janakiram from Royal Pearl Hospital and ENT Research Institute, India, and I have done this dissection along with my residents. We start with a diagnostic nasal endoscopy using a 0-degree telescope, and this is the aircraft technique. The landmarks being the inferior turbinate, the middle turbinate, and the superior turbinate. The sphenoid os can be seen in your picture. That's the axillary ostium which can be seen there. That's the floor. In the aircraft technique, the endoscope takes off in the anterior end of the inferior turbinate, flies between the middle and the inferior turbinate, and lands in the nasopharynx. Now we will see the landmarks in the nasopharynx. That's the eustachian tube orifice. That's the fossa of Rosenmuller and the region of the adenoids. Coming backwards, that's the axilla of the middle meatus, the uncinate process, the free border of the uncinate process, the bulla et modale, and that's the hiatus seminaris inferioris. That's the axillary ostium. That's the base of the triangle where we'll have to do an uncinectomy, bullotomy. The first step in the procedure is lateralization of the inferior turbinate with a Freer's elevator at the level of the anterior end of the middle turbinate. We never destabilize the middle turbinate at any given point during the procedure. We use a backbiting forceps and engage it at the antero-inferior quadrant of the bulla et modale, corresponding to the upper 2/3 and lower 1/3 of the uncinate process. The lower portion of the uncinate process is dissected submucosally. We can see the attachment of the uncinate process to the inferior turbinate. It's a U-shaped attachment. And then we debride the mucosa of the medial aspect of the uncinate process using a micro debrider. We have devised an uncinate flap, and you're going to see how we do the uncinate flap. We take a sickle knife and submucosally dissect the horizontal portion of the bone of the uncinate process. You can see very well the bone is being dissected away. Care is taken not to damage the mucosa on its lateral aspect. We can also see the natural ostium very clearly there. The mucosa on its lateral aspect is being gently teased out and the bone being elevated. This bone can go posteriorly till the palatine bone. We are dissecting that bone of the lower portion of the uncinate process. And once the bone is dissected out, we remove that bone with a Blakeslee forceps. The mucosa on its lateral aspect is preserved. That's a Blakeslee forceps being used to remove the bone. Now we make a horizontal incision on the superior posterior border of the natural ostium, connecting it with the axillary ostium. We can do this with a sickle knife or a scissors, and we connect the natural ostium with the axillary ostium. The second step in uncinate flap is that we make a vertical incision along its anterior end. So we have a rectangular flap and this is laid over the inferior turbinate. The reason why we do this flap is because the whole area is not made raw and it is draped with mucosa, and hence the incidence of ostial stenosis is very less. And that is why we do the uncinate flap. This is a 70-degree view of the maxillary sinus, and we can see the interior of the maxillary sinus, the intraorbital nerve, and the posterior wall of the maxillary sinus. Now we go for the upper border of the uncinate process. We use a ball probe and we tease the uncinate process and we debride away using a micro debrider. It is not advisable to shear the upper border of the uncinate process because we need to see the superior attachment of the uncinate process, and that will give us an idea of the drainage pathway of the frontal sinus. We are now using a 70-degree telescope, and that's the Aganasi cell. Now we are going medially, posteriorly, using a frontal ball probe, and we push the Aganasi, that's the half egg, forwards and laterally, and now we are able to see inside the frontal sinus. We are now seeing the posterior table of the frontal sinus. The frontal butt is seen very well. The next step is to do a bullotomy. The bulla has got 6 walls. We puncture the bulla in its anterior wall. The anterior and inferior quadrant is punctured. We use a micro debrider and we once open the bulla, we are now able to see the basal lamella, in fact the retrobullar recess. We are now using a debrider and the bulla is being removed. We generally preserve the inferior wall of the bulla, and to do an anterior skull base dissection, we remove the suprabullar cell using a frontal ball probe, and once we remove the suprabullar cell, we are now able to see the anterior ethmoidal neurovascular bundle. That's the anterior neurovascular bundle. The frontal recess is seen very well. The anterior portion of the fovea, anterior ethmoidal neurovascular bundle is seen very well. The next step would be to puncture the basal lamella. The basal lamella is punctured inferiorly and medially, and then the Blakeslee forceps is used to bluntly dissect the posterior ethmoid cells. In this cadaver, we will be actually shearing the mucosa out, but in a live situation, we would like to preserve the mucosa. We take off the mucosa here to just demonstrate the anatomy. That's yet another cell in the posterior ethmoids. We are now entering that cell. The posterior ethmoid cells are more rectangular and larger than the anterior ethmoid cells. That is the posterior most ethmoid cell being entered. We can see that the skull base, the posterior skull base is tapering downwards. And now that's a 70-degree view. That's the anterior ethmoidal neurovascular bundle, the anterior fovea. That's the close-up view of the anterior ethmoidal artery. That's the posterior fovea, and the posterior ethmoidal artery is seen very clearly there. That's the posterior ethmoidal artery. Roughly corresponds to the anterior face of the sphenoid sinus. The next step would be to open up the sphenoid sinus, and for that we follow the intermediate approach. We create a superior meatal window. The landmark for creating a superior meatal window would be the inferior wall of the bulla leads us on to the superior meatal window. Once we debride the posterior aspect of the middle turbinate at its junction with the bulla, we have a glimpse of the superior turbinate. You can now have a very nice view of the superior turbinate, end-on view of the superior turbinate there. That's the superior turbinate seen very clearly. A Freer's elevator is used to gently push it laterally. The inferior third of the superior turbinate is punched out using a Karl Storr's true cutting forceps. It is advisable not to take the whole of the superior turbinate, but just the inferior third of the superior turbinate. And once this is done, the sphenoid os, the natural sphenoid ostium, is seen very well. And we use a Stamberger's mushroom punch to widen the sphenoid os. This instrument is a very useful and delicate instrument for widening the sphenoid sinus. It prevents injury to vital structures like the optic nerve or the internal carotid artery. We use this punch to take away the bone till the skull base, and then a debrider is used on its lateral aspect till the orbital apex, till the lamina papyracia. Now the sphenoid sinus is opened very wide. You can see the optic nerve, the orbital apex. That's the optic nerve. That's the internal carotid artery. Very nicely seen in your picture. And that's the sellar floor. That's the posterior ethmoidal vessel, the skull base, and the lamina papyracia. Once we go behind the middle meatal antrostomy, in this cadaver, we had a posterior halar cell. That's a halar cell. That's a posterior halar cell, and once we see a halar cell, we are supposed to connect it with the middle meatal antrostomy. Halar cells can be anterior, middle, or posteriorly placed. They reduce the size of the maxillary os. Now, we trim off all the bony spicules, and at the end of the procedure, we should have a smooth looking cavity without any bony spicules hanging down. That's the final result we'll have to achieve after a total sphenoethmoidectomy. That's a skull base, that's a posterior skull base, that's the anterior ethmoidal artery, that's a remnant superior turbinate, the middle turbinate very stable in your picture. The next exercise would be an endoscopic dacryocystorhinostomy. For that, we make an incision 2 millimeters above the anterior attachment of the middle turbinate, and we carry this incision 1 centimeter forwards. We then make a vertical incision. We usually use an inferiorly based flap. We use a Cartel's elevator to elevate this flap in a subperiosteal plane, and this flap is draped over the inferior turbinate. We can already have a look at the nasolacrimal duct, which has been exposed now, just anterior to the middle meatal antrostomy. We can see that on external compression. External compression is being given, and when we look at it endoscopically, we are able to see the movement there. The lacrimal bone, which is a very thin bone, has been removed. We start removing the ascending process of the maxilla using a Hadad punch in its inferior aspect. There are several ways to remove this bone. You can use a drill, you can use a mallet and a gouge, but we use a Hadad punch because this is very quick and very precise. The superior aspect of the bone is very thick, and here we use a mallet and a gouge, or we use a drill. You can see us using a mallet and a gouge here. Adequate bone exposure is very essential to prevent recurrence and failure. Now you can see that the whole lacrimal sac has been fully exposed. The whole medial wall should be exposed. Once we do that, we make a vertical incision more towards its posterior aspect using a sickle knife. That's a vertical incision being given. And then we use a backbiting forceps and we punch the inferior portion of the lacrimal sac. We then use a ball probe to enter into the sac. You can see the ball probe entering the sac very nicely. The next step would be to use the upturned scissors to create two flaps. The anterior flap and a posterior flap. These flaps are draped over the bone in such a way that the whole of the medial wall has been fully exposed. And the two flaps are in contact with the mucosal surfaces, which are going to be repositioned. The inferiorly based mucosal flap will be repositioned now, and that will be in contact with the anterior flap. Care is taken not to expose raw bone, because raw bone will produce fibrosis and will lead to failure of the procedure. It is not advisable to take this flap out at all. Now you can see that the anterior flap is in contact with the inferiorly based flap, which has given us excellent results. That's the posteriorly based flap. The next exercise would be a sphenopalatine artery ligation, and for that we make two incisions. One, a vertical incision, which is just posterior to the posterior aspect of the middle meatal antrostomy. The posterior incision is being given, a vertical incision, and that's the horizontal incision made above the superior aspect of the inferior turbinate at its posterior end. And then a subperiosteal plane is created and it is dissected to expose the crista ethmodale. Now we can see the crista ethmoidale very clearly. The crista ethmoidale is a bony ridge which forms the anterior boundary of the sphenopalatine foramen. You can see the crista very nicely there in your picture. That's in fact the mucosa of the Haller cell, which is going to be removed now. That's the sphenopalatine artery. Now we give a mild stretch, medial pressure over the middle turbinate, and that stretches the artery. And then we can see the sphenopalatine artery very clearly. And once we do that, we can either clip it or ligate it or diathamize it. Dissection posteriorly will now expose the palatovaginal canal, which is along the floor and anterior wall of the sphenoid sinus, which transmits the pharyngeal nerve. It's inframedial, and supralaterally will be the Vidian canal. That's the Vidian canal over your picture. The next exercise would be exposure of the Pterygopalatine fossa, and for that we use a Hedgeck-Koffler push to take off the crista ethmoidale, and we'll also remove the posterior wall of the maxillary sinus. Once the posterior wall of the maxillary sinus is removed, it's usually removed the diamond burr in a live situation. You can see the descending palatine branch very clearly there. That's the terminal branch. We keep removing bone. The periosteum behind the bone is being exposed. And once we incise the periosteum, we will be directly over the internal maxillary artery. In the Pterygopalatine fossa, the vascular structures are seen anterior to the neural structures. We are now teasing the pad of fat in the Pterygopalatine fossa. The Pterygopalatine fossa communicates with the infratemporal fossa through the inferior orbital fissure. That's the internal maxillary artery being delineated very clearly in your picture. That's a pad of fat being slowly separated. We are now using a debrider to tease out the fat, and now we'll have a glimpse of the maxillary nerve, which continues as an intraorbital nerve. That's the maxillary nerve coming out of the foramen rotundum. The maxillary nerve continues as the infraorbital nerve. The Pterygopalatine ganglion is suspended in the maxillary nerve, and the Vidian nerve comes and ends in the Pterygopalatine ganglion. And this gives rise to the greater and lesser palatine nerves. We can see the maxillary nerve very clearly there, and the internal maxillary artery just anterior to it. That's the internal maxillary artery, the maxillary nerve going as the infraorbital nerve. That's the Pterygopalatine ganglion giving off its branches, very clearly seen there, suspended from the maxillary nerve. That's the ganglion. And this is how we ligate the internal maxillary artery. And once the dissection of the Pterygopalatine fossa is completed, we move on to the next exercise, locating the Vidian nerve. We either cauterize or clip the Sphenopalatine artery, and then once we do that, we will have a look directly onto the Vidian nerve, which comes out of the Vidian canal. That's the Vidian canal there. In fact, that's a very important landmark for the internal carotid artery. That's the palatovaginal canal, internal maxillary artery, the Vidian nerve coming and joining the Pterygopalatine ganglion. The next exercise would be an orbital decompression, and for this we use a Freer's elevator to remove the lamina papyragia and care is taken not to remove the lamina papyragia. It has to be removed 5 millimeters below the level of the frontal ostium, because once we remove it above, then it will obstruct the frontal ostium. The bone is taken from the level 5 millimeters below the frontal ostium till the infraorbital nerve, and this is called 1.5 orbitod. And this gives retrogression of 5 millimeters. We can see the medial rectus muscle there. As we go posteriorly, the medial rectus muscle is very close to the lamina papyragia, and as we come anteriorly, the medial rectus is hidden by fat. We can now see that we are going inferiorly towards the infraorbital nerve. This is called 1.5 orbitotomy. You can see very clearly the bone is being removed. And now we are proceeding on to the next exercise, namely optic nerve decompression. That's the orbital periosteum. It's advisable not to remove or incise the orbital periosteum till we do the optic nerve decompression, because the fat prolapse will obscure the view of the optic canal. Once we decide to do an optic nerve decompression, it is better to remove the bone medial to the optic nerve and then incise the orbital periosteum. That is the medial rectus muscle. In a live situation, we would like to use a diamond burr to remove the bone over the optic tubercle. But here in a cadaver, we are using a cutting burr. The bone on its medial wall is either thin or dehiscent or thick. In this situation, it's very thick. Removal of bone can be done either 180 degrees or sometimes even 270 degrees. The ophthalmic artery runs on its postero-inferior quadrant. So care is taken when we remove bone inferiorly so that we don't damage the ophthalmic artery. That's the optic nerve. The bone is being removed from its medial wall. That's in fact the bony canal surrounding the optic nerve. The optic nerve has got a length of around 1.5 to 2 centimeters in the sphenoid sinus. In a 1OD cell situation, the optic nerve could be dehiscent, and during dissection we should be very careful when there is a 1OD cell situation, and the optic nerve can be easily damaged if we don't read a CT scan properly. We are now removing a bone of the optic canal. In a live situation, it's better to use a diamond drill, make the bone eggshell thin, and then it's better to remove the eggshell bone with a Freer's elevator. We are now using a drill and then a Freer's elevator. And once the bone is taken off, we incise the sheath. The incision of the sheath is given from the 1 to 3 o'clock position on the right side and 9 to 12 o'clock position on the left side. Now you can see that we are incising the sheath, and this completes the optic nerve decompression. And if we have to combine it with an orbital decompression, we make an incision on the orbital periosteum in the H-shaped manner. Care is taken not to injure the medial rectus muscle. And once we compress the orbit, the fat prolapses medially, and this gives a retrogression of 5 millimeters. Now we can see the medial rectus muscle. The next exercise would be preparation of a Hadad flap. For surgeons venturing into anterior skull base surgery, reconstruction part is as important as the excision of the tumor part. Hence, reconstruction should be planned before the surgery. The first step in doing the Hadad flap will be resecting the middle turbinate. You can now see that we are resecting the middle turbinate. Care is taken when we resect the posterior end of the middle turbinate not to injure the vascularity of the flap. The flap gains its vascularity from the posterior septal artery, and you can see now that we are incising the posterior end of the middle turbinate. This flap is the workhorse for surgeons venturing into the anterior skull base surgery. That's the posterior end of the middle turbinate being excised. In fact, we can have a glimpse of the sphenoid os and the superior turbinate there. The first incision is made on the superior aspect of the choana. That's the choana, the superior aspect, and that's the level of the incision. The incision is made using a 15-blade knife. It is carried inferiorly along the floor of the nasal cavity. The next incision is made along the floor of the sphenoid sinus, and it is carried along the roof of the septum and then a Freer's hemitransfixation incision is used to connect both these incisions. Once the two incisions are connected, the flap is elevated in a submucoperichondrial plane, as we do in septal correction. That is the incision on the floor being given. A laser or a diathermy can be used to make this incision, because in a live situation there can be bleeding while making this incision. That's a plane of dissection. And now the flap is pushed posteriorly. It's turned laterally towards its pedicle. That's a choana. And sharp dissection should be used here. And we secure this flap in the nasopharynx. Tissues were a little bit rubbery because it's a cadaver. Some surgeons secure this flap in a middle meatal antrostomy, but we don't do that. The next step would be to widen the sphenoid sinus ostium on the left side inframedially. That's the internal carotid artery. That's the sella, the optic nerve, maximal exposure should be achieved for dissection of the tumors in the pituitary. We believe in a 1.5 exposure, a cavity and a half. Now we are doing a posterior septectomy. A debrider is being used to remove the septal mucosa on the other side. A cavity and a half gives maximum exposure to operate on tumors in the cellar, suprasellar region as well as on the clival region. You can see how wide the exposure is right now. You can see the intersphenoidal septum now in the midline of your picture. The intersphenoidal septum usually ends in the internal carotid artery on one side. It's never in the center. We use a bone punch to take the intersphenoidal septum out. It is better not to avulse that bone because it might get inserted on to the carotid, which might be dehiscent and it might lead to complications. The next step, we expose the sphenoid keel we make 2 shoulder osteotomies and remove the floor of the sphenoid sinus. We believe that when we are operating on the pituitary, we should have 2 suction tip exposure below the sellar level. This completes the nasal stage of dissection. We go to part 2. Here we are going to show draft 3, transcribriform approach, transplanar, transtubercular, sellar, retrosellar, pituitary transposition and transclival approaches. We have done a total sphenoethmodectomy on both sides. This is another cadaver, a second cadaver. The first exercise is a draft 3 that we are going to show. It's otherwise called MEL, Modified Endoscopic Lothrop, as a first step to transcribriform approach. This involves resecting the middle turbinate on both sides. If you are doing just draft 3 procedure for a frontal rhesus problem, then we will not be excising the middle turbinate. Since we are doing a transcribriform approach, we are resecting the middle turbinate on both sides. We have resected the middle turbinate on the left side now. And the middle turbinate on the right side is also being resected. That's the middle turbinate on both sides, which have been resected. The next step in draft 3, the median drainage, would be debriding away the mucosa anterior to the middle turbinate on its lateral wall, and also debriding the mucosa over the septum as well. The same procedure is done on the other side. The mucosa of the septum is removed to a length and a height of 2 by 3 centimeters. 2 by 3 centimeters. We are debriding the mucosa anterior to the middle turbinate on the right side and over the nasal septum. Once this is done, the next step would be the identification of the first olfactory neuron. And for that, mucosa over the middle turbinate and the septum in the region of the olfactory cleft should be elevated and pushed gently posteriorly so that the first olfactory neuron is exposed. It is very important to identify the first olfactory neuron because this forms the posterior limit of dissection. In this cadaver, we use the navigation equipment. We will also be demonstrating the first olfactory neuron with the navigation equipment. We can see very clearly the first olfactory neuron. That's the first olfactory neuron. That forms the posterior limit of dissection. The same procedure is repeated on the left side. The mucosa of the middle turbinate and the septum, and that's the first olfactory neuron. The next step would be creating a septal window size of a 2 by 3 centimeters using a septal punch forceps. Now we can see the septal window is being created. Adequate amount of septal mucosa as well as the cartilage should be removed so that the frontal sinus from one side can be visualized and operated from the other side. The posterior end of this window would be the anterior end of the middle turbinate. Now we are using a backbiting forceps to widen the septal window anteriorly. Once the septal window is created, the navigation probe is used, and this clearly demonstrates the posterior limit of dissection. You can see that on the sagittal view, the first olfactory neuron. That's the posterior limit of dissection. The same is confirmed on the other side as well. We then start drilling the frontal process of the maxillary bone. Drilling is done using a 4 mm cutting burr, and drilling is done anteriorly and laterally. It should never be done medially because this will lead to entry into the skull base. We should always do it anteriorly and laterally. The advantage of this burr is that we have an irrigation channel in this burr as well. And now you can see that we are drilling anteriorly and laterally only and never going medially now. Now you can see the frontal sinus very well. That's the posterior wall of the frontal sinus, very clearly seen in your picture. That's a curved navigation probe being used to confirm that we are inside the frontal sinus. This cadaver had a very small frontal sinus on both sides. That's a navigation probe, a curved navigation probe by Karl Storrs. Once we have ascertained the posterior limit of dissection, we'll have to curve towards the other side. The whole part of the dissection is done using a 0-degree telescope and a straight burr. The same procedure is done on the other side. And now we are curving medially, as you can see. Moving towards the left side. The same steps are repeated on the left side. Note that the drill is being used from the right side, the right nostril, and the dissection is being done on the left side. The lateral limit of dissection is the skin just superior to the lacrimal sac fossa. That's the lateral limit of dissection in Mel. The ultimate size of the opening would be 18 by 24 millimeters. You can see the skin there very clearly there. That's the skin. On external compression, you can see it moving there. That forms the lateral limit. That's external compression being done. And now we turn medially. Modified endoscopic Lothrop for frontal sinus procedures can be used for refractory frontal sinusitis. It can be used for inverted papillomas. It can be used for ECC neuroblastomas, osteomas of the frontal sinus, laterally based cells, fractures of the posterior table of the frontal sinus. Here, we are showing this procedure as a first part of transcribiform approach. You can now see the frontal sinus on both sides have been connected. The interfrontal septum is being drilled away now. This can be compared to the facial ridge in modified radical mastoidectomy, and care is taken to reduce this ridge, the interfrontal septum, flush with the posterior table of the frontal sinus, so that an oval looking cavity is created. You can see that the interfrontal septum has been reduced very nicely. The final part of draft 3 procedure would be to reduce the frontal T. The frontal T is formed by the anterior end of the middle turbinate on both sides and the superior edge of the nasal septum. Extreme degree of caution should be exercised when we reduce the frontal T because we may enter into the skull base if we are very rash during this step. Tumors that don't involve the posterior table of the frontal sinus and just posterior to the frontal sinus, we need not do a draft 3 procedure. But tumors abetting the posterior wall of the frontal sinus, like for example, meningiomas, olfactory groove meningiomas, esthesioneuroblastomas involving the posterior table, we'll have to do a draft 3 procedure. We are now reducing the frontal T to convert it into an oval looking cavity. Now that's the navigation probe being used, Karl Stohr's navigation probe, to touch the posterior table of the frontal sinus and also the first olfactory neuron. And then we transect the nasal septum so that the nasal septum is totally detached. And now we are debriding the remnant middle turbinate. This is the intrasphenoidal dissection. A silk cut forceps by Karl Stohr is being used to remove the intrasphenoidal septae. This forceps is a fantastic forceps to punch out the bone. If we try to shear the bone, there might be injury to the internal carotid artery or vital structures. But this forceps clearly punches out the bone so that it doesn't shear the bone out. Now we can have a very clear view of the nasopharynx, and we are debriding away the nasal septum till the floor. And this is very essential for transclival approach. It has to be taken till the roof of the soft palate. It should be reduced flush till the floor. That's the sphenoid sinus, the sella. The bluish hue is the superior intercavernous sinus. Now you can see the navigation pictures. and that's the clivus, the pointer, the hairline on the clivus. Now we start the trans-sellar approach. We're using a mallet and a gouge to remove the floor of the cellar. A diamond burr can also be used to remove the floor of the cellar. And once we remove the bone, we elevate the bone, and the limits of bone exposure in cellar dissection would be the 4 blues. Dura is exposed now. The limits of exposure would be superiorly the superior intercavernous sinus, inferiorly the inferior intercavernous sinus, on either side the cavernous sinus, and that is called the 4 blues. Now we can see that the bone is being exposed till the cavernous sinus laterally. You can see that the punch forceps is being used as an elevator. And this I learned from Professor Daniel Privedelo. And then would be a transplanar approach. To do the transplanar approach, we'll have to remove a wedge-shaped bone. The base of the wedge is formed by a line just posterior to the posterior ethmoidal artery, and the 2 sides of the triangle just above the optic canal. We can now see the diamond bar being used to drill the base of the triangle. We can see the posterior ethmoidal artery on the left of your picture very clearly. That's the dura which has been exposed. And then would be a transtubercular approach. For the transtubercular approach, we drill the bone like a curve. In fact, the curve on both sides delineates the internal carotid artery. It's like a cobra on a peanut. The 2 cobras are the internal carotid arteries, and the peanut is the pituitary gland. So, for a transtubercular approach, the bone is drilled in a curvilinear fashion on both sides. Now the bone is removed from the planum sphenoidale. That's a triangular piece of bone, the wedge. And once we do that, that's a triangular piece of bone on the planum. And this is the bone in the tuberculum sella region. Now we have opened the dura just superior to the superior intercavernous sinus in the region of the tuberculum sellae. We make a U flap, a superiorly based U flap, and once we do that, we reflect the flap superiorly and we see a layer of arachnoid inside. You can see the optic chiasm very clearly and the pituitary stalk behind it. And we slowly, gently separate the arachnoid layer. And once we do that, we are able to see the pituitary stalk. And the structures we see are the superior hypophyseal artery on the left of your picture. That's the superior hypophyseal artery. That's the optic chiasm above. That's the internal carotid artery. The superior hypophyseal artery is the first intradural branch of the internal carotid artery. It gives off a descending diaphragmatic branch, the subchiasmatic plexus, and the recurrent optic branch. This branch is a very important branch because damage to this branch will lead to blindness. Now we are seeing the suprachiasmatic region. This approach is a very useful approach for tumors going above the optic chiasm. That's the suction tip being used just above the optic chiasm. The pituitary stalk very clearly seen. We're using a 30-degree telescope now. The skull base, the suprachiasmatic region. You can now have a look at the pituitary stalk, the optic chiasm. The next exercise would be a pituitary transposition. This exercise and technique has been described by Professor Amin Kassam and colleagues from the Pittsburgh University. This is done for retrocellular lesions and tumors involving the interpeduncular fossa. The dura is elevated from the pituitary gland and a subdural dissection is done. The pituitary gland is suspended laterally by trabeculae, and that plane is a very important plane, and we can dissect that gland out and you can see the plane very nicely. And this is where the inferior hypophyseal artery will be there. And the same is done on the left side as well. The subdural dissection is done. The dura has to be dissected all 360 degrees for us to transpose the pituitary upwards. You can see how gently it's being done. That is the region of the superior intercavernous sinus. Care is taken not to injure the superior hypophyseal artery. The inferior hypophyseal artery is transected. That is the superior intercavernous sinus on the left side. In a live situation, we would like to diathermize it before cutting it. And now the pituitary is being lifted off the dorsum sellae. And it is being rotated upwards. That's the dorsum sellae, from which the pituitary gland is being separated. That's again the dural attachment, which is being cut. At the end of this procedure, the pituitary gland will be suspended only by its stalk and the superior hypophyseal artery. It will be rotated above and fibrin glue will be used for it to stay there. And once the pituitary transposition is done, the gland is turned upwards, rotated upwards, and the view of the liquid membrane is got. And once that is perforated, we can get a view of the interpeduncular fossa, and the mammillary bodies can be seen very clearly there. Suction is being used to suck the CSF there. That's the mammillary bodies seen very nicely in the picture. We are now using a 70-degree telescope to perforate the tuberous venarium. And once that is done, we can have a look at the third ventricle. Now we'll have a glimpse into the interior of the third ventricle. We are now sucking the CSF. The telescope is advanced inside the third ventricle. And now we can see the foramen of Monro, the thalamus on both sides, the aqueduct of Sylvius. That's a wonderful view of the third ventricle. The choroid plexus can be seen there. ENT surgeons who have got doubts about the structures have to verify the text. Since we have marked all these structures in the text, you can see the mammillary bodies there. The next exercise would be a transcribriform approach, the anterior craniofacial resection. The first step would be to delineate the anterior and the posterior ethmoidal artery on both sides. And for this, we drill the canal of the anterior ethmoidal artery on both sides, and in a live situation, we cauterize it at the point of its entry into the intracranial cavity. It's not advisable to cauterize it at the point where it enters the orbit because it can retract into the orbit, producing retrobulbar hemorrhage. That's the posterior ethmoidal artery being, the canal being drilled out with a diamond burr. The posterior limit of dissection would be the planum sphenoidale, and the lateral limit of dissection would be the lamina papyragia. This is a very useful approach for olfactory groove meningiomas, esthesioneuroblastoma, A diamond burr is used to drill out the bone and delineate the dura, and then cautery is used to cauterize the dura, and finally the dura is incised and the skull base is removed en bloc. That's the posterior wall of the frontal sinus. The crista galli has to be separated at this point, and already the skull base has become mobile. It's attached only to the falx cerebri now. The falx cerebri is cauterized and sharp dissection is used to cut it. You can now see the scissors being used to cut the falx cerebri. That's the falx cerebri. And now we can see the olfactory tract. In fact, we're cutting the dura now. We can see the olfactory tracts on both sides. The gyrus rectus is seen very clearly. That's the bone of the skull base being removed en bloc. That's the bone of the skull base, superior portion of the septum. Now this is a 70-degree view of the gyrus rectus on both sides, the frontal lobes on both sides separated by the falx. We are now cutting the dura, the region of the planum sphenoidale. Care is taken not to injure the anterior cerebral vessels. Now the dura is being reflected over the orbital apex on both sides. A clear view of the olfactory bulb is seen. Dura is being reflected on the orbital apex. And now we are trying to demonstrate the anterior cerebral vascular bundle. That's a clear view of the anterior cerebral artery on both sides, the A1, A2 and the ACOM. That's A2, ACOM, A1. The next step would be having a glimpse into the upper clivus using a 30-degree telescope, looking from above downwards. we are able to see the posterior cerebral and the superior cerebellar artery and the basilar artery there, the third nerve on the left of your picture. Once we suck the CSF, we are able to see the third nerve very clearly, the posterior cerebral artery there, the basilar artery there, behind the dorsum sellae. That's the posterior cerebral. The ventral part of the upper clivus is bounded by the dorsum sellae and the posterior clinoid laterally. That's the dorsum sellae being dissected out. This is the approach to the upper clivus. We make two shoulder osteotomies using a diamond burr. So that we separate the posterior clinoid process from the dorsum sellae. It should be remembered that the pituitary gland is a part of the upper clivus. In fact, we call the upper clivus pregnant with the pituitary. We are making two shoulder osteotomies and the bone in between is removed. You can see the dura behind. Care is taken not to injure the dura. That's the bone being removed. In a live situation, the posterior clinoid process is posterolateral to the internal carotid artery, and it is thinned out with a diamond burr, and it is slowly teased out so that there is no damage to the internal carotid artery. Now we are here removing the posterior clinoid with a ball probe. That's the posterior clinoid process. This is on the right side. That's the posterior clinoid process being removed. And once that is done, we will be proceeding on to dissecting the middle and lower portion of the clivus. And for that, adequate bone should be removed. The lateral limit of dissection would be the paraclival carotid and the Vidian nerve above, the medial pterygoid process below, and the eustachian tube below. The paraclival carotid and the Vidian nerve above. We should not go too laterally while dissecting the bone. The Vidian nerve is a fantastic landmark for identifying the carotid artery. That's the carotid on either side. We have to remove the bone till the floor of the sphenoid sinus, and that is removal of the soft tissue of the nasopharynx, the pharyngobasilar fascia, the longus capitis, longus colli muscles. The navigation equipment is extremely useful to delineate the lower limit of dissection and to determine where the foramen magnum lies. That's the navigation probe being used. And you can see that we are right on the clivus right now, and we are going down now, still further low, and right on the foramen magnum now. In fact, the Karl Stohr's navigation is a very user-friendly tool, and we have been using that for a long time now, and we find that this equipment is very, very useful when we do the clival dissection. We are now using the debrider to take off the longus colli and the longus capitis muscle. The lateral limit of the dissection would be the eustachian tube on both sides. A cutting burr is being used to take off the floor of the sphenoid sinus. In a live situation, if there is bleeding, we use gel foam paste. And now the soft tissue is being taken out using a debrider. The bone is being drilled out now. You can see the dura very clearly. This is a fantastic exposure for tumors involving the clivus, like clival cardomas. That's a navigation probe being used now to determine the lower limit of dissection. Now we're using scissors, a down cutting scissors, and we start cutting the dura in the midline. We have to strictly adhere to the midline. Because we should not damage the sixth nerve, which goes laterally. It takes its origin at the level of the VBJ. That's a basilar artery coming into view. We are now using a sickle knife to cut further down. That's the dura being cut. In a live situation, it's better not to take off the arachnoid, but here in the cadaver, we would like to take off the arachnoid layer and show the anatomy better. That's the arachnoid being teased out. You can see the third nerve, the posterior cerebral artery, the PCOM, the P1 and the P2. A clear view of the pons. You can have a glimpse of the sixth nerve there. That's very near the PCOM. The arachnoid layer is being teased out very gently. You can see the basilar artery. That's the VBJ. We are going to use an angled telescope to view inferiorly and laterally to demonstrate the various cranial nerves. The cranial nerves we see are, that's the 12th cranial nerve, that's the 6th going laterally into the duralos canal. The sixth going into the Doralose canal, very clearly seen. That's the third nerve. That's the fourth nerve being dissected. It's a slender nerve coming from the dorsal aspect of the brain. Six. You can see the 7 and 8 with the labyrinthine artery. That's a 12. The 9, 10, 11 behind it. 12th is more ventral. That's a 12. That's a vertebral artery coming inside into the interdural course. That's the suction tip being used. You can see the vertebral artery very clearly entering. The 12th nerve. The 11 behind it. The 9, 10. Twelve, 7, 8, 6, fifth nerve complex there above the sixth nerve. The 4, the 3rd, basilar artery, and now that's the optic chiasm, the final look, and that's the second nerve and the first nerve. So all the cranial nerves can be seen by this approach, and just a final look at the anterior cerebral artery, the A1, given off from the internal carotid artery. Thank you very much.